Kropski, who is visiting us from Vanderbilt. He is a prolific physician scientist who is leading the field with his research, focusing on the genetic basis of ILD and also the molecular mechanisms in lung injury and repair. He studied medicine at Vanderbilt University School of Medicine and has subsequently been somewhat of a lifer at Vanderbilt, completing residency in pulmonary critical care medicine there with fellowship. He participated in the Harrison Society Physician Scientist Training Program as well, and began on faculty in 2014 and has worked his way up in the ranks. He's currently associate professor in both the Department of Medicine and the Department of Cell and Developmental Biology. He's the division's research director and holds the Rudy W. Jacobson Endowed Chair in Pulmonary Medicine. Over the years, he's won multiple awards for clinical excellence, for exemplary teaching, and for outstanding research. He's notably quite collaborative as a research scientist. He's supported by numerous grants and awards. He's published more than 80 peer-reviewed articles, dozens of reviews and editorials. And in addition to his own work, he's a key mentor for multiple trainees at various levels of education. So for the topic today, it really strikes me that over the past decade, it has been really increasingly evident that the role of genetic predisposition is of particular importance in pulmonary fibrosis. The more we look for familial lung disease, the more we find it. And the more we find it, the more we discover that it really affects everyone around the patient, their family members as well. And so the research into this area really helps us to rethink the field, and it's really helping us give meaningful information to people in their clinical lives. And it has diagnostic and therapeutic implications. So I'm really interested to hear this talk today, talking about genetics and early detection in pulmonary fibrosis. So welcome.
Well, thank you. Thank you, Danielle, for a very, very kind introduction. And I really am grateful for the opportunity to be here. And as I had said, this is my first trip to Yale. So I'm really, it's been wonderful to get to see friends, meet new people, and get to learn about all the exciting work going on here. I'm going to try to be a little bit provocative to stir the conversation a little bit. So I'd love to sort of get input, feedback, and thoughts on this as we talk through this topic, and thus the title, which is I think we need to think a little bit differently about how we've framed pulmonary fibrosis, and this is going to be really hopefully primarily a clinically oriented talk around what we should be doing and thinking about this. Have a few disclosures, grants from a couple of companies. None of this is really particularly relevant to any of this today. So it is a grand rounds, and so I wanted to start with a case. This first case, I think, is emblematic of a thing that we see these days. I do my clinical care at our VA, and so this 68-year-old guy, he was a paratrooper. He was seen in the ER for a kidney stone, got a CAT scan, and they commented on minor scarring in the lung bases, recommend a dedicated chest CT, which he gets, and you can see here. So that prompts a little more conversation, and it turns out, he smoked while he was in the military. He's been out for a long time, quit a long time ago. Like many paratroopers, he has very bad degenerative joint disease, and so he's really not active these days. He lives in Middle Tennessee, and like all people in Middle Tennessee, he has pretty bad allergies. He's got some reflux. He's not really short of breath. He has somewhat of a cough, but he's not, and didn't make too much of it. He's adopted. You get pulmonary function tests, and these are what you see: flow capacity, TLC, DLCO. I've been excited about the promise of some of these quantitative approaches to measuring fibrosis in CTs. So hypothetically, you used a quantitative measure, and he has 2.8% of his lung volume has fibrosis. And so the question that I put to the group is, what do we call this? Is this person normal? Is this person have an interstitial lung abnormality? Does this person have interstitial lung disease? Has anybody seen anyone like this in the recent? Of course, right? And so then the obvious questions are, well, what do we do? Nothing. I think if this was 15 years ago, that's probably what would have happened. I'm not sure that's right. Probably wasn't wrong at the time. Should we start him on antifibrotics? Should we do a lung biopsy? Bronch them, use the genomic classifier once the reagents come back in, maybe. Should we repeat a CT scan in a year, get PFTs in a year, measure telomere length, do genetics? What should we do? This is basically an asymptomatic person with some not trivial, but not extensive imaging abnormalities. And so I want to contrast this with a slightly different scenario of the same age individual, but let's say he's a New York City banker and he gets an executive physical and he has this CT scan, which shows minor scarring in the lung bases, and you get this. Now, let's say, he never smoked. He's a real avid cyclist, likes to ride. He rides 40 to 60 miles a week. He's gotten a little bit slower over the last few years. He's got similar comorbidities. He's not specifically short of breath. He's riding a little slower. He does have a little cough, maybe. Let's say mother and brother had idiopathic pulmonary fibrosis. You can see his pulmonary function tests here. They're all normal. And hypothetically, since it's the exact same CT scan, because I made these cases up to be illustrative, same amount of fibrosis. So now this is someone who's like maybe possibly a little bit symptomatic from this. What do we do this? So I think that this is an increasingly emblematic of the sorts of patients that we're seeing as they come in. And I think we need to figure out what we want to do with them. So before we can get to sort of the answer to that question, I think we have to wrestle with sort of the way that we set up guidelines and how we make diagnoses. And this is the flow chart of how to make a diagnosis of IPF from the 2018 ATS-ERS guidelines. And I think folks who do ILD in the room are relatively familiar with these. And frankly, this hasn't changed very much over time. But I want to highlight sort of this first step. So patients suspected to have IPF. Okay. So I kind of feel like as we have learned more about this over time, by the time we suspect somebody has IPF, like they've got something. The horse is out of the barn to some degree. And I think at least my perception is that if we're going to move the needle, by the time people are having extensive symptoms from disease, which leads them to seek an evaluation, they've already lost a lot of lung function. And we need to be acknowledging that that is not the beginning of disease, even though that's the way our guidelines are written right now. So people may disagree with me on that, and I would love to discuss that point further, but I think that the concept that we define this biological entity by non-specific insensitive symptoms that are effort dependent is really difficult to justify scientifically, for what that's worth. And just to put some numbers to that. Okay, so let's look at like PFTs from recent IPF trials. If you'll notice, just 3 of the more recent sort of high profile ones, the PDE4B inhibitor, autotaxin inhibitor, integrin inhibitor, all over the last couple of years, these are all the same, right? People are about 80% vital capacity and about 50% DLCO. So they've lost 50% of their vital capacity before these people are getting into clinical trials. And these are the people that we see clinically, right? This is sort of the bread and butter of the clinic, but they've lost half of their gas exchange. That's a ton. And the analogy to me is like not treating hypertension until somebody has a stroke. Like we would never do that. So we need to sort of move the needle back. And so the way I think that we really should be thinking about this as an entity is not that pulmonary fibrosis is a yes/no, but pulmonary fibrosis is just one of a thing that is a continuous trait. And by the time people develop symptoms, they've already got extensive imaging abnormalities and they've already got extensive PFT decrements. Yet we all know that there was a big window before that something was going on. And so I think that presents a challenge, but it presents an opportunity. And I'd like to sort of talk a little bit for the rest of this about how we're sort of trying to understand that. But this is when we're treating people, is that we are treating people once they've already got really late stage disease. When I talk about early IPF with people, this is one of those things that I think if you ask 10 pulmonologists what early IPF is, you'll get 10 different answers. And so to some people, I sort of have this conversation and they'll say that early IPF is somebody who has a definite UIP pattern CT and a diffusion capacity of 60 and a vital capacity of 80. And if you biopsy them, you have a clear UIP lesion. And I would say that's late stage disease. Early is that which has not even yet become UIP pathology. And so just when I say early, that's what I mean, but that language is not aligned across everybody.
So the clinical scenario you're setting up is the same that was faced with heart failure and the New York State Heart Association classes and the grades, like by the ACC and European Heart Association, states this by staging it and classifying it. So,
Oh, no, there we go. So I was just asking, saying that heart failure faces the same problems and attempt to address this by at least categorizing on a functional status by New York State Heart Association classes and then the ACC AHA grades. Why don't we have anything like that for IPF?
I think we should. I think our community is a little late to the game, but I think that is exactly what we should be doing. And I think if we did that, then that would create I'm sort of jumping to the end, but if we could do that, that's a paradigm where then we could test stuff, because that's how they do this for chronic kidney disease. That's how they do this for heart failure. That's how they do this for all sorts of other chronic diseases. And we don't have to invent this. Like, this is a paradigm that others have used effectively. We just need to be willing to embrace it and embrace that is not how we have always thought about this. And inertia is powerful, but sometimes we need to break free of its chains, to be overly dramatic. So what do we know about early disease? So I want to talk a little bit about genetics, and I want to talk a little bit about sort of natural history of early disease and what are things that matter about it. So pulmonary fibrosis, it's a gene by environment syndrome. I think everybody acknowledges that at this point. And in terms of risk factors, family history is the single strongest risk factor. If you have a family history of idiopathic ILD, multiple studies have kind of hit on the same number, that you're probably about 600% as likely, 6 times more likely than someone who doesn't to develop an idiopathic interstitial lung disease. And this is not a new idea. Familial aggregation of ILD cases date back more than almost 75 years now. This sort of seminal report from Dr. J. Winthrop Peabody that was published years and years ago. And I think a lot of the description in this paper is still pretty apt, although I would argue that idiopathic pulmonary fibrosis being so unusual that its occurrence in identical twins can hardly be attributed to coincidence is perhaps overstated, but this is an old idea. So when we think about ways that heritable risk is conferred, there's kind of 2 buckets that these things fall into, with a little bit of a caveat that we'll talk about. But genetic risk for disease tend to be either highly penetrant Mendelian traits. These are things like cystic fibrosis. These are things like autosomal dominant cardiomyopathies with the sort of heart failure analogy. These are familial cancer syndromes. And then there are also common genetic variants that individually confer relatively small effect. These are generally what we think about as mediating underlying disease risk through polygenic mechanisms. These are things that you find from GWAS studies, right? And so if we think about the sort of familial clustering of pulmonary fibrosis, what do I exactly mean by that? There are a few different nuanced definitions that have gotten used in the literature. And the general consensus, trying to assimilate these, is that about 1 in 5 IPF patients with significant ascertainment will be identified to have another family member who has an ILD. And the FPF definition requires at least 2 bloodline related individuals with an ILD. And there's a little bit of difference from sort of one study to another about whether like non-idiopathic phenotypes will be included or not, and how closely related people have to be. And that probably affects interpretation a little bit. But I think the point of this is that like looking at large, the age at which these people are identified to develop disease, it's about the same as sporadic ILD. And importantly, seeing different disease patterns within the same family is not unusual. It's almost the norm. And so on the top of the screen, just data from the UT Southwestern group showing that in this paper from Chad Newton, these are all short telomere families, just a real diversity of different diagnoses. And this seminal paper from Mark Steele that's almost 20 years old now, I can't believe, which showed that like 50% of families have discordant histopathology or imaging-based diagnoses. So it's okay. They don't all have to have IPF. This familial aggregation, I think we need to think a little bit more broadly about. And as we'll talk about, I think the genetics support that assertion. So the first gene that was linked to familial ILD was surfactant protein C. I'm not going to spend a lot of time talking about this. Big multiplex family, candidate gene-based approach, linkage evidence, and this was really informative about how the disease works, because this is a gene that is restricted to a single cell type in the lung. It's an epithelial restricted gene in type 2 alveolar epithelial cells, and mutations in that are sufficient to cause interstitial lung disease. And so that really was sort of, I think, some of the most compelling evidence around sort of the current conceptualization of disease around epithelial injury and dysfunctional repair of it driving this. This is rare. It's probably less than 3% of all cases of familial ILD. So it's biologically informative and rare. Since then, mutations in surfactant, other SFTPC mutations have been identified, SFTPA2 in particular, SFTPA1. So there is a unique phenotype that seems to go with those other surfactant mutations, which is a really dramatically increased risk of cancer. In some of the cohorts, up to 50% of people with SFTPA1 mutations with ILD will develop cancer, strikingly high risk. ABCA3 disease is more of a neonatal one, and you tend to need biallelic variants. So surfactant-related adult ILD, one copy of a mutation is enough. These are toxic gain-of-function mutations. So the other thing about this is that it's actually not, you're not going to confuse this for IPF, usually. The imaging features are kind of weird. And so I think an unusual looking pattern in a young person should be a clue to this. So these are just some examples from a paper of the different sorts of patterns you can see, but there can be ground glass, there can be funny cysts, there can be very geographic patterns of disease, there can be honeycombing type stuff in non-dependent areas. So lots of different patterns, but I think as a clinical phenotype, these people, that disease progresses, it progresses at least as quickly as everybody else. They just get disease when they're a lot younger. There questions as to what to do about them is complicated. There's not a lot of these. The data that we have are sort of case series level. Standard of care antifibrotics get used, I think, not inappropriately. It seems like, again, it's not clear whether they have a differential effect. It's probably not better in these patients, but might be comparable. There are some anecdotal reports of immune modulator responses, especially in very, very young people. And these can be good lung transplant candidates. They often are relatively young, may not have a lot of other comorbidities. So the real things that I think are exciting about this and important about this are, one, if you find somebody with this sort of a very early onset disease, abnormal imaging, thinking about the SFTPA2 mutations and how we should be lung cancer screening them, like these are people that even though the guidelines are not written as such, like that penetrance of lung cancer is so high, we should be lung cancer screening these people. I know that is not in any guideline, but I think it's the right thing to be doing. And then the other thing that's exciting about these is like these are very monogenic diseases in a single cell. And so these are the kind of things that are, I think, going to be the first place in ILD that we get precision therapies, either targeting sort of the downstream mechanisms of these mutations, whether that's the unfolded protein response or integrated stress response, or potentially sort of more genetic approaches, base or prime editing, or cell therapies. So these, I think that that's where the next generation of like really sort of out there therapies is likely to land. But this is a small piece of the pie. The more frequent monogenic cluster of genes are the ones related to telomeres. This became, this was described in 2007 in a pair of papers, one from Mario Armanios, one from Christine Garcia, that identified rare variants in telomere-related genes as the most frequent monogenic causes of pulmonary fibrosis. Again, these, generally speaking, don't occur in completely isolated clinical scenarios. So they generally occur in the setting of a personal or a family history of a short telomere syndrome. And so what are the features of this? Premature graying, bone marrow dyscrasias, which can actually be a lot of different things. Macrocytosis is very common, but thrombocytopenias, MDS, AML, aplastic anemia is common. Cryptogenic cirrhosis, or massled, I guess, would be the right way of framing this, and somebody who doesn't have other metabolic phenotypes to go with that. And then something that has not been vetted, I think, as comprehensively as it needs to be, but there may be genetic anticipation in families, and that's been argued that it's related to sort of progressive telomere attrition. And there's definitely examples of families where it's like generation 1 pulmonary fibrosis, generation 2 cirrhosis, generation 3 aplastic anemia. That's probably variant dependent to some degree. There have now been several large sequencing studies that have, I think, aligned quite well in terms of the relative prevalences of these. And so this is, again, just a table sort of outlining data from Columbia and from our group, either whole genome or whole exome sequencing families with pulmonary fibrosis. As you can see, TERT variants are the most common. These other telomere-related genes probably sum to somewhere around 10%, and surfactant genes are super, super rare. And so you may note that those numbers don't sum to 100%. They barely sum to 25%. And I think that this is an important message that has come from this work over time. I sort of started my science career with the plan that like we would just keep sequencing these families, we'd find more genes, we'd write more grants about trying to figure out what that gene does. And there's a few more percolating, but I think the lesson that we've learned is that like familial disease is not all monogenic disease, and that we really do actually have fair clinical phenotypes that we've just talked through that can like identify these sort of rarer Mendelian people. And then there's familial disease at large. So just to talk very little bit more about these sort of short telomere folks. These are the people that have the extreme phenotype. So they are younger at diagnosis, which I realize I think is not on this slide, but this was a study that one of the residents in our group and I have been working on, just taking all the short telomere telomerase mutation families and comparing them to other familial cases in sporadic IPF. And what we found is that while sporadic IPF patients are 75% men, if you look at folks in families with telomere mutations, it's 50-50, like that male-female breakdown goes away. Smoking prevalence is considerably lower in those short telomere folks. There's not differences in like their PFTs at baseline, for example. And then if we look at sort of outcomes, the telomere mutation folks develop disease 5 to 7 years earlier. They have more rapid FVC decline, and they're the ones that have decreased survival. And so like en masse, if you look at the rest of the familial folks, they kind of just look like what we would have called sporadic disease. And so I think that my message that I'm trying to argue for is that the familial clustering can be a clue that it might be monogenic, but familial does not all mean this, and that these people with specific defined genetic trajectories are really the ones with like the extreme phenotypes. Okay, so that's that. Now there is like the complexity to this, these genetic etiologies cross clinical phenotype boundaries. So there's study from French group looking at rheumatoid arthritis associated ILD, study from UCSF looking at chronic hypersensitivity pneumonitis, and this same pattern of genetic variants related to telomere biology primarily. You find it in about the same frequencies, not exactly, but like pretty close to the same frequencies, suggesting that there at least can be a shared underlying genetic risk across these different phenotypes. And just like you see in the IPF patients I was just talking about, the telomere mutation patients with hypersensitivity pneumonitis, they do worse. I think that a question as to why that is, the answer to that might be that they are particularly prone to adverse outcomes from immunosuppressive therapy. So this was, again, not data from us. This is data that from I think a really nice and important paper that Dave Zhang and Chad Newton published last year that looked at the effect of azathioprine or mycophenolate on outcomes of patients with non-IPF related ILD using telomere length as an interaction term for this. And what they found was that specifically among people that had short peripheral blood telomeres, these are not all people with known monogenic causes, but at least short peripheral blood telomeres, they did substantially worse, substantially increased risk for premature survival or premature mortality if they were treated with these cell cycle inhibitor immunosuppressives. So like, I think this presents a real clinical conundrum that was like talking about with Danielle this morning. Like, what do you do with these people then? And I don't think we know. I think this is a thing that needs to get studied. And corticosteroids in particular is also, there's kind of not a clear signal about whether or not the same adverse outcomes would be the case here. But this is aligned with post-transplant data suggesting short telomere folks also have more cytopenias, increased risk of sort of CMV reactivation. So I think that this genetic information, it is influence how we approach to treating people. And it's perhaps even more informative in the people that sort of aren't just IPF patients where we already know we're like not going to be giving them immunosuppressives. So I do think that this is impactful. And we need to collect information. We need to study this to sort of know what the right answer is to do. Okay, so there is one other like elephant in the room genetic thing that I wanted to talk about a little bit because I think it's interesting and it's complicated. So there's also this common variant risk factor, this promoter polymorphism in the gene encoding for this airway mucin MUC5B. And if you recall, this was not found in a GWAS. This was identified in a linkage study in families with pulmonary fibrosis and then has been replicated repeatedly in more than 11 or 12 different cohorts at this point. But this is a common genetic variant, right? You find it in 18% of non-Hispanic whites, very prevalent in the general population. And yet its odds ratio for IPF is 6. And if you have 2 copies of the risk allele, it's 20 times more likely to develop pulmonary fibrosis, like incredibly strong risk factor. So a question that comes up is like, well, can't we use this as a screening test then? We screen everybody that got MUC5B genotype. Okay, then we should do something about this. And the problem is that it actually doesn't work. So just to sort of do the like math on that. So assuming an IPF prevalence of 1%, which is probably, an IPF prevalence of like 0.1%. Here's sort of how the test performance works out. So based on the minor allele frequency, you can get a sensitivity of up to about 60% for cases. But the positive predictive value of a MUC5B risk genotype for developing pulmonary fibrosis is like 3%. So that's just not, you just can't use that as a screening test. The negative predictive value is actually quite high. So one could argue that that isn't terrible as a rule out test, but why would you do a test to rule out a screening test to rule out a rare? It doesn't make sense. Now, the flip side of this, and that's still not well understood, is that even though this is a strong risk variant for pulmonary fibrosis, if you have IPF and you've got the risk variant, you do better. That's weird, right? That does not make sense. But this has been, again, replicated in multiple cohorts at this point. So if you've got this risk variant, you're at 6 to 20 times more likely to develop pulmonary fibrosis. But if you develop it, you're going to do better in the long run. And sort of the same thing about shared genetic risk across disease phenotypes. This holds for the MUC5B risk allele as well. So minor allele frequencies are about the same in chronic hypersensitivity pneumonitis, and they're about the same in RA if you have a UIP phenotype, but not if you don't. So I do think that this is sort of honing down on these like some of these genetic things are really conferring like disease phenotype independent risk. And I think the reason that we're seeing these differences in outcomes related to these different genotypes is just that these are sort of identifying groups of, they're identifying different groups of patients. So like if you look at our telomerase mutation cohort, the MUC5B risk allele is much less common among people with telomere pathway rare variants. So in some ways, like the reason I think that those MUC5B people look like they're doing better is just that group is depleted for the people that do worse, which is like sort of a convoluted way of thinking about it. But I think it means that these are just not, that we shouldn't be lumping them exactly. So, we've been trying to think about how does this all fit together? So this is a somewhat convoluted visualization of it that Rafi Fernandez, one of our fellows, and I tried to put together that is attempting to make the point that there is monogenic ILD, but it's not all familial ILD. And actually not all the monogenic folks, not all the monogenic disease happens in somebody who already has a known family history. So if you like do sequencing studies of sporadic IPF in people who don't have a known family history, you'll still find some of these same variants, just probably at about only about 25% as often. So lower frequency, but same variants. But that these monogenic forms of disease are pretty rare. Familial disease is more common, but a lot of familial disease is probably polygenic, and there's not going to be one gene that we can nail down that explains all of it. And then there's sort of idiopathic ILD, which is both sort of fibrotic and non-fibrotic phenotypes. And within fibrotic ILDs, there's sort of all of the other sort of clinical entities that we're accustomed to. But I think that sort of framing this a slightly different way, we've got increasing evidence that there really are different genetic risk mechanisms that confer different outcomes. And the only way we're going to know what the right thing to do for all of these people is to gather the data and to be able to study this. And so even though we don't know exactly how we should be using this information for everybody yet, I think the only way we can is to have that information to be able to sort of look forward and see how these people do and respond to different therapies and that. So that's my plug for how we should be approaching this as a field. Not everybody agrees with that. And I think you can make an argument that we aren't necessarily doing an enormous amount of things differently right now. So why do it? But I think that this is where we are going. And this is where other diseases are going. And again, I think we need to embrace this. So there are some guidelines that have been put forward. There was a group, the PFF group that included genetic counselors, basic scientists, clinician investigators, laid out a schema. This is a perspective we wrote a few years ago. But I think like the way we should actually use this genetic testing today is informed by what we just talked about. Like we should think about testing people where we've got a high pretest probability of finding something, but we shouldn't be doing this for everybody. At least right now. How we talk about different iterations of that, but I think somebody who's got a high pretest probability of surfactant disease or short telomere disease, those are the folks that there's value in doing this from. There are challenges, right? A negative genetic test is never an informative test, and that's a hard thing for people to get their head around. That's a hard thing to counsel. There are cost and insurance issues, although I think that's getting better. There are implications for other people in the family. This is different than other things that we do clinically. Doing a test on one person may mean something for their siblings and children. And then what do you do if you get results back that you don't know what to do with? Variants of uncertain significance. And, there are better and better and better tools, and there's more, I'd say large scale functional assays that can be done that are going to improve our ability to classify these things, but it's not perfect. And these are real challenges, and it's hard for somebody who's busy in clinic to do this. And so I think that really the way to do this is with strong support from genetic counseling. And there are a number of places around the country that have really built out programs around this. And they're always happy to see these folks. I think this is something that is probably more than we can be asking everybody doing ILD clinically to be doing at the moment. Okay, so just to close in the last few minutes, I think the other big question that I wanted to sort of get at is that question around well, what should you do with everybody else? And so, right, these are I just put some pedigrees up here for the sake of sort of showing that these can be highly penetrant in families, but what should we be doing for other people in families who have pulmonary fibrosis? Should we be screening them? So this is a question that we've been working on for a long time now. This is this cohort study that we set up about 15 years ago. A couple of Tim Blackwell, Jim Lloyd were a couple of my mentors who set this up in 2008. Margaret Salisbury in our group now runs this study. But this is a prospective cohort of siblings or children of familial ILD patients. And the point of this that's a little different than some of the cohorts that have been done is we work really hard not to ascertain people who have IPF that just haven't seen a doctor. Anybody who's really got any attributable symptoms, we send them for a clinical evaluation. We don't want them in this study. This is trying to find people before they have disease and watch it evolve over time. And so the concept behind this was that as we do that, eventually we'll know who goes on to get disease and who doesn't. And we can start to work backwards and figure out what was different. How can we predict who's going to go on to develop disease? Just to tell you a little bit about this cohort, and there are a few other places that have built similar ones over time. This has now got over 540 people in it. Median age at the time they're enrolled in the study is about 53. A little bit of a female predominance, which has been that's just who participates in research. And I think you can see the MUC5B genotype prevalence is it's high. So that just within the cohort at large, it's higher than background. And so that is one of the things that, as I'll talk about, that genotype, even though in other cohorts it associates with ILA risk and stuff, it doesn't here. But I think it's just because the background rate's really high. And importantly, I show PFTs. These people have normal PFTs at the time they're getting into the study. And so what has been really remarkable through the course of this is that 25% of people have early interstitial lung abnormalities at the time that they get into the study. Now, we don't define ILA the same way it was in the Fleischner guidelines. These would be indeterminate by Fleischner guidelines. And I'll talk a little bit about the implication of that in a couple of minutes. But these are people who have definite things that are not normal, but they're not at least 5% of a lung zone that would qualify based on Fleischner guidelines. Now, what's really striking is that age matters a lot when you screen people. And really strikingly in this cohort, once you get above 65 or 70, the prevalence of ILA is 50% or more. So it's incredibly common in these high-risk family members. How are they different? So if we look at folks with and without ILA, the folks who have ILA, they're older, no surprise there. Sex doesn't predict anything. MUC5B genotype doesn't predict anything. Telomere length actually doesn't predict anything. This is a cohort that has only a small number of individuals. So actually have known monogenic variants in it. So this is not driven by a handful of people that have TERT mutations or something. The only thing that is different is their DLCO is technically normal, but on the lower end of normal among folks who have these early ILA. Okay, so I talked about genes, we talked about environment. So are there any things that people are exposed to that might be particularly problematic? So we have tried to look at this a little bit. This is a study that Margaret led a couple of years ago where we tried to get around the sort of recall bias in most sort of ILA occupational studies. This was an environmental exposure questionnaire people did before they had their first CT. And then we scanned them and then went back and looked and said, okay, are there any occupational or other exposures that are associated with it? And like, perhaps not surprisingly, like birds and mold are associated with ILA in this cohort. There are a few other things that fell out. One of them that was just really striking was aluminum smelting. Seems to be like not frequent, but it seems to be really particularly high risk. And that's sort of something that's shown up in a few studies. So I think that like this kind of information like is still useful in like counseling people. Like, you have a really strong family history. Well, like I would probably not be an aluminum smelter, for example. Seems sort of obvious, but I think it's useful. Okay, what happens to these over time? So it turns out that if you've got one of these ILAs, the way we define them, which are very mild, nonetheless, their risk of progression is very high. So if you've got an ILA, 70% of them will progress over the next 5 years, about 30% of them won't. The other thing I will say is that as we keep adjudicating these people every about 5 years, we keep finding new ILA that develop during the course of study. And so not surprisingly, age and lower lung function tests, those are folks that tend to get worse. Again, the things that we at least originally had thought would be like decent biomarkers of predicting progression, like telomere length and MUC5B genotype, like haven't really played out in this cohort.
So these are people with ILA that the family have.
Correct.
So this isn't like, I'm sorry, these are people who have ILA within families who have pulmonary fibrosis.
Correct.
This isn't the same as people who have ILAs in the general population.
This is a high risk cohort. And I think although it's a high risk cohort, at least in terms of like, for example, the allele frequencies of all the GWAS loci, if you look in these familial folks and sporadics, it's the same. So I am uncertain that this doesn't translate. Even though it's a super high risk cohort, we need to look at this. And there's been a little bit of data others have done in sort of population-based studies. And it depends how you quantify progression, but even in population-based studies, the detectable progression rate seems to be 50% plus in like all of these, which is it's really wild. And it creates a conundrum of like, if ILA is in 7% of smokers over 50, and yet IPF is a 1 in 1,000, 10,000 disease, what's missing? And I think what has to be missing is there's just like people who aren't being classified as anything. Like the people that are not being classified as anything at all. They're just not being diagnosed or adjudicated in any sort of way. I don't know what else that could possibly explain it.
So one quick clarification, what's the time axis on this?
About 5 years. It's the study visits are approximately
Because-
5 years. So
It wasn't clear in the paper, actually.
okay, gosh, sorry. Yeah, it's not perfect. The median follow-up, I think, is like 6.1 or something. But so I just, two things take away from that. They almost all progress. They don't progress fast, which again, presents an opportunity, presents a challenge. But just to sort of, okay, what happens in the next epoch? So we follow people from scan 1 to scan 2. What about scan 2 to scan 3? The pattern holds. You keep getting about 70+% of these. If it's progressive, it almost always keeps progressing. There's a small number of folks that seemed stable and will start to progress. But over time, the progression is real. This is like an extreme example of like detectable progression that probably is really clinically inconsequential right now. But like this is somebody at enrollment at 5 years, at 10 years. And there's no question that there's been a little bit of reticulation that's gotten worse. And I agree, there is no question that this is like physiologically not consequential right now, but there's people with much more extreme examples of this. But I raised this with the point of this is primarily to say that like, if we're ever going to do like an interventional study, the idea that this could be done using like PFT based metrics as the endpoint is like just not going to work. Their PFTs are normal. They're just not going to change that much during this time. Okay, so just to sort of put all of that together, I've got a couple more slides here, just sort of showing like what is different among folks. And this paper that Naftali is alluding to just came out like in the Blue Journal like 4 days ago or something like that. So we compared people who had serial imaging, who had no progression, versus a group that we lumped calling subclinical FPF. And subclinical FPF, I just mean somebody who had ILA that got worse or had a normal scan who developed a new ILA. So that's a lumped measure. And if you look at, what's different among those people, those with subclinical FPF are older, but otherwise, like clinical and exposure things didn't really explain much, like no difference in sex, no difference in smoking, no difference in MUC5B genotype, no difference in telomere length. Their PFTs, again, DLCO is actually a little bit lower. TLC is statistically a little bit lower. And just to like, I guess, put a nail in like how consequential are these things? So out of those like 73 people who had progression events, 47, so 64% of those were folks who went either from nothing to something or something to radiologically worse, but 26 of them are ones who have developed sort of clinical symptomatic disease. So like reasonable number of these, that's almost 1 in 10 people in this longitudinal part of the study have gone on to that to develop symptomatic disease. So I think that's fairly consequential. Now, how extensive the abnormality is, does that matter? So I think this is the other really important thing that I wanted to sort of capture from this is that we then looked at whether you like would have met Fleischner criteria for ILA or not. And so if you met Fleischner criteria, which we called moderate ILAs, those folks compared to folks who had no ILA were 17 times more likely to progress during the study. But even those people who had something that would be called indeterminate, would not be considered sort of anything that required specific monitoring or follow-up by those guidelines, were still 9 times more likely to progress. So huge risk factor. And it turns out there's actually like certain imaging features that you can use that are like, these are things that we look at and we talk about and we think about that do provide some information on progression risk. So like if you've got bilateral reticulation, that is extremely likely to progress. Whereas if there's just like a unilateral scar, that's not going to progress. Ground glass, if you have a little bit of ground glass, it's not. But if you have bilateral ground glass, that's actually bad. Those people are at high risk of progression. And then the other thing that was a little bit surprising to us was that there's a non-trivial number of these folks who have like biapical scarring, which I think now we would say is like PPFE-esque. And those people also, even though we sort of don't, at least I hadn't classically thought about that as something that I worried about more extensive progression, like those people are at higher risk of ILA progression. And just, so I think this is ILA progression. There's data from a bunch of different groups. This is from Colorado and from the COPD gene cohort, looking at sort of the implication of this on survival. And like these people, they may not all be dying of progressive ILD, but there is a survival impact of this. And so just to close, I think, I hope I've made the case that like familial ILD is like pretty common, but it's not all monogenic, and that's okay. I think we need to just acknowledge that, embrace that, and then use that information when we think about who would be appropriate for genetic evaluation. The second thing is that at least among high risk cohorts, these interstitial abnormalities are incredibly common. I think it is almost impossible not to say that we really need to be screening these individuals and probably other high risk populations. And then just to close, that the extent of the abnormality, even stuff that is pretty minor has a considerable risk of progression. And so I think that all these threshold-based metrics, like you have to define stuff somehow to study it. But I think as a clinician taking care of folks that show up like this, like we shouldn't be dichotomizing these things into yes, no. We should be acknowledging that every little bit more is more worse. This is where I think we need to be getting to through the course of the next few years, is really moving towards a secondary and hopefully in folks who we may have sort of antecedent genetic information, even thinking about doing primary prevention type studies. And then just, a shameless plug. This study is still enrolling. If you have folks that you think would be interested, it's a national cohort. We can't pay for travel, but we can pay for hotels. So if they want to take a vacation to Nashville, and then come see us, we would be delighted to see them. There's a bunch of exciting stuff nested into this right now. There's a personal exposome study that Margaret's leading. There's a bronchoscopy sub-study that I'll talk a little bit about tomorrow that we've been doing using single cell genomics and spatial genomics and other things to try to really get at these like early disease mechanisms. And so we're enrolling the bronchoscopy study as well. So if there's folks who'd be interested in that, holler at me. We would be delighted to get to see them. So just, lots of folks have been involved in the things on our end, and really grateful for like a super network of friends, colleagues, collaborators, funders, and the like. And I'm happy to take any other questions, comments, and feedback.
That was a terrific talk. Thank you. Yes.
I think it's on.
Okay. Perfect talk. Thank you. And it looks like we have any questions from the doctor.
I want you to talk about those two guys, the two people you started to talk with.
Oh, I didn't come back to him. Yeah. I'd see him back with PFTs and a CT in a year.
And then the second question was?
I don't know if that's right, but that's what I do these days.
And the second question was on their thing. So
I would offer them to join. Well, yeah, the one who had a family history, I'd send him to the early IPF study.
Right. So that was the question, which is on your summary slide. You said the time has come for more active screening of familial of that, and probably other high-risk populations. What does that mean, and who are those people, and why do you think that?
Yeah. So again, this is opinion. There is a ATS clinical statement that is being drafted that recommendations will come out around these things in the relatively near future. I think this is my opinion, that at least for like first degree relatives of familial cases, I think we should. Who are the other high risk populations? I think in this case, I'm talking about largely like CTD populations that there's not necessarily screening going on. So like everybody with systemic sclerosis, rheumatoid arthritis, like that probably a one-time scan probably makes sense, but I hedge on that a little bit more. Now, what do you do with first degree relatives of a patient who just has IPF? I don't know. That one is complicated. I think that the data from the Brigham group is provocative and suggests that you frequently find that they have ILA prevalence that's like comparable to the folks without a family history, but it's really small numbers and sort of referral. So I don't know, but that might actually be the right answer in the future.
So yeah, as you know, I really enjoyed your paper. I highly recommend the paper that came. I actually tweeted about it, and also whatever it is. I don't know how you call it, skeeted, like in the sky.
Yeah,
Skeeted, I think. Anyway, so I think it's critically important, and I completely think that this was long time waiting, the evidence that we have. But then you do have, so I'll ask you two questions which are separate. One is philosophical, which are disease mechanism. I think your data and also some of our single cell data suggests that we're actually the disease is actually a disease of the gas exchange barrier. Basically, the fact that the majority of what is called in the community early IPF shows up a little bit like kidney failure, with 50% of the lung gas exchange capacity gone, suggests that maybe the fibrosis is even the secondary process, but it's definitely not the driving of the early disease. So what do you think about this? And how does it impact actually your thinking about drug discovery? And then I'll ask you the next question.
Okay, so Naftali's question is basically is fibrosis a secondary process? Is it not the problem? I mean, that I do think of this as fibroblasts are doing what they're told, and that the cues for them to sort of activate and elaborate matrix, that's their context. And this is not a fibroblast tumor. This is not an autonomous disease that's doing that. So I think that presents an opportunity where if we could get at the cues that are ongoing in sort of blood gas barrier as it is being dysregulated early on, like I think of this as like the, end stage fibrosis, maybe someday tissue engineering people way in the future could like fix that. But what if we just got at like the recoverable, slightly abnormal areas and could poke them back towards health? Like that is at least my short term, I feel like vaguely scientifically and functionally tractable like thing that could be done is, could we salvage not yet completely architecturally remodeled like alveolar units? And if we could do that, I think that we could basically stop disease progression. And this is just something people live with, but it's not necessarily something that is relentlessly progressive and a huge cause of morbidity and mortality. So I agree, not surprisingly.
And the other question, which is very practical, which is you said about the family members of patients with sporadic IPF. I've always wondered whether we should test them for MAC5B, because if they're negative, they have nothing to worry about.
Probably. Maybe.
So maybe there is a justification for genetic screening in that.
Maybe. Yeah. That's an interesting question. I mean, that's we need to, there needs to be a large cohort enrolled to capture people that way. And that's been attempted, but hasn't been done. Yeah, I don't know. The other case that, I've told a couple of people about this today, that like, genetics are, it's actually incredibly cheap to like sequence something. Like it's way cheaper than like most of the things that we do. Like it wouldn't be surprising if we're just, I don't know, 10 years from now, like we're just all going to have our genomes, like it's already going to be done. It's going to have been done for some reason or another. And then we could at least use that information up front to potentially inform how we would do screening and things like that. That's a whole nother kettle of fish.
Dr. Manning?
So thank you. Wonderful talk. I wanted to follow up and see if we could keep following heart failure and get your impression on something, because specifically there's nice similarities and differences with hypertrophic cardiomyopathy, fibrotic disease located in a single organ. It's much more common, hypertrophic cardiomyopathy, 1 in 500 or even more frequent. More than 50% though are genetic, and the stumbling block that they had in that field is that there was no good genotype-phenotype correlation, which I think you're alluding to across the board, with the exception of some genes you can. But the real stumbling block they had was the structure-function relationship. Structure should precede dysfunction, like structural changes, and it's hard to biopsy the heart. So other than like late gadolinium enhancement, they're stuck.
Yeah.
But we're not in the lung field. And I think you showed that evidence very nicely, that we can actually see these changes even without a biopsy and imaging. So am I interpreting kind of your future direction as saying we should focus on the structural changes in the imaging in addition to other tools and the genetic tools we have? And maybe do we need a new, better way to quantify the changes we're seeing that specifically addresses this population?
Yeah, so those are wonderful questions, and I really do like this analogy a lot. I think it's very apt. So on the question of, should we be, I think to take the last part of it first, like the classification scheme, I do. I think we need to rewrite sort of the way that we do this and have a not symptomatic pulmonary fibrosis like that, whether we do this as stage 1, 2, 3, however, some formulation like that does need to matter. Now, I think that the question of should we be anchoring to the ILA, I think we actually need to go further back than that. So to extend that analogy, like macro structure, I think needs to sort of follow with pathology. But at least my conceptualization of this is like, molecular pathology happens before anatomic pathology, and anatomic pathology happens before you can see it on a scan. And once we can see it on a scan, like actually a lot has already gone wrong. And, we've done bronchs and cryobiopsies, transbronchs in people who had normal HRCTs, who have gone on to develop interstitial lung abnormalities, and they're molecularly not normal, like nuclear seq wise, which I think I'm going to shuffle a little bit more of that into tomorrow's talk based on this. So I do think that there's like a real window and an opportunity there. But the challenge, and I think what we need to do is understand what is it that's abnormal then that can be modeled, because I think what holds us back is bad models that only model one aspect of disease. In this earliest part of it, I don't think that we have a tremendous handle on like how well any of our models are recapitulating it. I think I forgot the first part of it.
Hey, John. Thanks so much. This was really great. I guess my question follows up on a little bit on what you're saying, which is, if you're trying to develop a marker for early stage, you can't really use a CAT scan, right? And, you're going to need to go to the molecular aspect, which is what you're talking about. And then the question is, where do you sample? Because we're not going to send our healthy people with a normal or near normal PFT and a normal CAT scan to go have a transbronchial of a random part of the lung because they have a family history, for example.
Yeah.
And then if Naftali is right, and this is all an epithelial barrier thing, then is that the only place where you go? So I guess my point are these genetic lesions located only in the epithelial barrier? Can you go, for example, to an immune cell, circulating cell, or maybe a nasal epithelial cell where you can actually find a lesion and justify the biopsy after?
Yeah. So we're trying, the only way to really answer that is to have a data set where you have, multi-site sampling of all of these things. And then can we correlate some lung tissue to something that is more accessible? And we're basically trying to do that right now. And to be, we in this study, in a study, we did do bronchs and transbronchs of people who had normal scans, and they don't all have normal pathology, and they don't all have normal molecular things. So, but I think point being, is that something that we're going to ever do clinically? No. But I think we need to anchor to tissue to know what we could ever use in circulation that's a surrogate. And I think, it might be that our biomarkers of late disease, maybe they actually work. Like maybe, they're sort of markers, they're leak biomarkers of cellular dysregulation. Maybe they would work okay. And to some degree, they probably do. I think we just need to sort of know what we can do to draw the arrow from, lung tissue to something in circulation that we could easily measure. That the nasal epithelium's interesting too. Exhaled breath condensates, and there's so many ways we try to get at this. Yeah.
Thank you. Thank you. You guys hear me? Thank you. That was a great talk. My question is more about the therapies. I'm thinking about the antifibrotics, and it would be, using your paradigm, it would be interesting to know how those patients with earlier stage disease respond to antifibrotics. I'm wondering if you're thinking about that or if you have any future directions to answer those questions.
So the best answer based on available data is like the INMARC trial basically did nintedanib in a population that had an average FVC over 95%. And secondary analyses of all the pirfenidone nintedanib trials seem like the effect size is conserved across FVC at least. So I don't think that there's reason to think that it wouldn't be effective in people who have relatively preserved PFTs. Now, to me, the question is that those are people who already are having FVC decline. If we go further back, I don't know, but I know there is a lot of interest in doing, and I believe that there is in the works going to be a sort of real early disease treatment trial coming. Because I think getting at the question I forgot to respond to was like, well, what would you quantify for that? And I actually think that CT might work. So I think there's lots of, right, all the quantitative imaging approaches are getting better and better and better. This is something we're working on. Anna Podolonchik and I have a project together that we're trying to like look at sort of different ways you could use sort of some of these different AI algorithms to do this. So I think it's got to be an imaging endpoint, although not everybody agrees with me on that. FDA needs to get behind it too.
Great, well, thank you very much. That was really just a terrific talk.